First and foremost, thanks everyone for joining us for another Industry Insiders webinar. As a part of the TCNJ Alumni Engagement Office, we bring these to you hopefully monthly. My name is Pam Persichetti. I'm the Alumni Engagement Officer at the college. So again, thank you for joining us for mental health wellness. There is a fantastic registration for this topic, which I think speaks to what people are looking to hear about and where their interests lie. So I'm really excited that we have such a great group, and even more excited that we have three wonderful alumni panelists who are very knowledgeable, seasoned professionals in the healthcare industry. And I'll give a quick introduction of each of them in a moment. But I do want to mention that we will do a question and answer session. Oh, make sure everyone's muted here. Question and answer session at the end, but certainly feel free to add your questions in the chat as we go. If we have some time, we can interject with some questions, but certainly we'll address them at the end as well. And even more so, if you'd like to unmute and have some interaction with our panelists, we welcome that as well. So without further ado, I will introduce our three panelists in no particular order. Brandon Bensley is an 08 grad, physics major. He is the Chief Science Officer and co-founder of Magnus Medical, and he's joining us from California. So thanks for doing this in the what's early for me in the morning over in California. I appreciate it. We have Zach Gull. He's a two-time alum of TCNJ and also a current employee at the college. He is a 13 and 17 graduate with degrees in English and psychology, and he is currently the prevention education specialist and therapist on campus. And finally, certainly not least, last but not least, Noel Ramirez is an 07 grad with degrees in communications and women and gender studies. And he is the founder and a clinician at Mango Tree Counseling and Consulting LLC. Thank you, all three of you, for taking time out today, but also in the planning of this and taking time out of your very busy schedules to join us. We really appreciate it, and sharing some very much sought out feedback and advice. We look forward to it. I'm going to let each of the panelists give a little bit more, just excuse me, I'm letting some people into the Zoom. Give a little bit more in-depth knowledge on what they do, just so everyone has a background. I think it's always nice to hear what our alum do and where they've kind of landed since graduating. So Brandon, I'll turn it over to you if you don't mind starting and kicking it off with a little bit of your background.
Yeah, happy to. And thank you, Pam, and thank you to Laura Smith as well for inviting me. I feel really honored to be here. And thanks to everyone for joining us today. It always warms my heart to see the interest folks have in mental wellness, and it's really great to keep building this community. So like Pam said, I graduated in 2008 with a degree in physics, and really enjoyed doing physics, but also I kind of realized that my true love was for understanding the brain. I actually went back to do a few more courses at TCNJ in psychology, and really enjoyed working in the psychology department there. And actually, Margaret Martinetti, who I believe is still there, was one of my really great psychology mentors, and really owe her a lot. Eventually, went down to continue to study neuroscience, formerly did a PhD in neuroscience, and also did my MD medical training. And then headed out to Stanford, where I did my psychiatry residency. So I'm a practicing psychiatrist. And then a couple of years ago, I had been doing research on new types of treatments for depression and discovered a really powerful way of treating depression. So I started this company, Magnus Medical, a few years ago, which is a med tech startup where we do actually human brain mapping and then personalized treatments for mental health. So I'm again, really happy to be here. Thank you.
I guess I will go next.
Yeah, awesome. Thank you.
Yes. Hello, everyone, and thank you, Pam, as well for having me here. Also very excited to see the interest in this, and hopefully we can answer some of your questions and provide some good guidance or thoughts on sort of the mental wellness area and industry. So yeah, my name is Zach. I graduated in 13 with a degree in psychology, and 17 with a master's in mental health counseling. And then, so I just haven't left since I was 18. I've been working here on campus for our Anti-Violence Initiatives Office for 6 years. And so most of my day, I'm a trauma therapist. And then I also work to promote education around bystander intervention and healthy sexuality, helping folks understand gender roles and the impacts of gender socialization on their experience. So my thing is really social psychology in addition to trauma recovery. So hopefully I can bring a little bit of that.
Oh, okay. Hi, everyone. My name is Noel Ramirez, class of 2007. And I just want to give a shout out to AAA and Barcata and PRISM. These were the organizations that I remember fondly and helped me in my trajectory of where I went after TCNJ. So, I graduated in 2007, which I tell people was a couple of years ago, but is actually a long time ago. And I started my professional journey as a bartender and a dancer at a nightclub. And what I loved about that experience was stories. And I loved hearing people's stories. I loved talking about things. I liked a little bit of trauma and depression. And so I would then slowly transition into a graduate program at UPenn in social work. And I worked in HIV community medicine for many years. I got a public health degree and also a doctorate in behavioral health, and really started doing work on addictions, community-based mental health work. And a couple of years ago, I started a Asian American mental health group practice called Mango Tree Counseling and Consulting. And we specialize in Asian American mental health. And I also teach graduate courses at Columbia and Penn around graduate social work and decolonizing social work practices. So I still love stories. I still love to talk to folks, and I still enjoy a little bit of trauma and drama, and that's me. And I'm just so glad to be here. Go Lions.
After hearing Noel's background, I don't think it will come as a surprise to learn that he won our Alumni Leadership Award, the Humanitarian Award, just this past spring at Alumni Weekend. So congratulations. Well earned, well deserved. So let's jump right into this discussion. And I hope that it can be a discussion format where the three of you and anyone else for that matter, if you want to use the hand raise feature or enter some thoughts in the chat, can really have a discussion about all things that we can fit in an hour, all things mental health. So in the planning call for this webinar, the four of us were on yet another Zoom. And one of the first things that I felt like jumped out as a point of passion from all three of you was access to healthcare and what that kind of looks like right now, and some difficulties in finding the right provider, or any provider is a little bit about what we talked about, and access points. So I'd like to start with that right off the top, because I know that stood out, and I think if anybody on this call has any experience, it probably stands out to you as well. So does anyone want to kind of jump in first about access to providers?
I'm happy to start out, and really I think the thing that I remember we all really resonated on, and I hear this from every single person that I work with in mental health, every friend and family member who's ever tried to access mental health, and then in my own work on more of the industry side and trying to get more resources for mental health, is that it's very difficult to access care for the vast majority of people. And the reason I want to start off by saying that is really to validate people's experiences, because I think a lot of people go on that journey not realizing, they feel like they're doing something wrong, or they messed up in some way, and that it should be easier for them. And I just want to start off by saying that it is really universally hard for everyone. It's due to a lot of systemic problems within the mental health system. And we do have, I think we all talked about a few things we'd love to share today with folks that are some kind of like tricks of the trade that might be helpful in some ways to get involved in advocacy, but do know that you're not alone in the challenge of accessing that system.
I was just going to say, there's like barrier number one, stigma, right? Acknowledging that we're having some stuff going on and we want to talk about it, right? So that's like the huge barrier psychologically. But the systemic barriers, like insurance, so in my practice, we do take health insurance, but that's not the norm in a lot of mental health group practices. There's private pay. Those fees are kind of high. And even with insurance providers, it's I will say, just as a provider, it's hard to credential people to actually get on the insurance panel. So that's kind of the hard concept here, is like even just us as providers trying to be a part of the system is difficult. A big part of my career has been about access to care in general across the board. But when it comes to mental health care, I mean, there's wait lists, pandemic for folks who are looking for mental health care. We saw like huge wait lists. And then there's also a significant shortage of psych providers, period. So I think we're just at a, and also just historically, like, I mean, the reason why some folks don't there isn't quite the greatest pipeline. There's a lot of stories around people not getting paid well in psych and the psychological workforce. So it's like a big supply and demand concern. And, just recently, I mean, think about this with the pandemic, just recently did most states and insurance providers say, hey, telehealth is okay, right? And so that lifted a barrier. But I mean, prior to that, when we're talking about competing priorities, locations, I think across the board, healthcare needs to be revised. Oops, I just got on a soapbox. But mental health, I think collectively as a subspecialty of healthcare is really difficult to access.
Yeah, and I think adding to those difficulties, and I think it'll sort of come up in our tips and tricks area too, is lots of the research into good and affirming mental health care talks about building a relationship with the clinician, and that the sort of like tab A slot B that might work with parts of physiological medicine don't work the same way in mental health. And that would be fine if there were tons and tons of providers that you could afford, that you could access, and you could shop around very easily, which I do encourage folks to do, but sometimes it's really hard, right? Sometimes you're on these wait lists or you're not hearing back from providers, and you get in front of someone and you're like, great, this is what I needed. And then to find out that you don't really connect with them, or that it's not as comfortable as you wanted it to be, or their specialty isn't exactly what you need. And it puts you in a place of sort of having to decide what's important in your care, whether it's access or whether it's comfort or whether it's efficacy. And that's not a great place to be. So it's sort of this additional systemic personal barrier that shows up. And I'm aware that we're presenting all of this sort of like bleak picture of the process. So like I said, we'll sort of get to ways to manage that, or potential ways through it as well.
And so, yeah, some of that, exactly, I was going to say. So in my notes from our call, we had discussed some ways to do it with insurance and some ways to do it without insurance, and maybe some backdoor, things like that. Could you expand on both of those?
And maybe something even even a small step before there. When I know we were going to come and have this webinar today, I reached out to my colleagues who are also mental health providers to ask them about their thoughts on this, to make sure that we were being comprehensive and I wasn't forgetting anything. And one of the important things a few people reminded me of is that if you're like me, or I think probably like most people, you typically don't call the doctor when you're doing your best. You usually wait till you're not doing well, because that's the motivation to call the doctor in the first place. It's really hard with mental health though, right? Because it's not typically somebody doesn't usually look out for a therapist or a psychiatrist when they're at their best. And when we're struggling with the most common things like depression and anxiety, both of those inherently make the bar really high in the first place for trying to reach out and do something that's really challenging at the best of times, which is find a provider. Really starting with kind of the bleak side of it and the difficulties of this, I think is really important, because in order to be successful with this, one of the things that I've seen and a lot of my colleagues have seen is that when people recruit their friends, their family, their social network to help them in the process. Because like I said, even at the best of times, it can be really disheartening when you're calling through these lists that your insurance gives you and you're like at number 45 and like no one's answered their phone and then no one calls you back for days. You're already in a difficult spot. So really having someone who can either just be a support for that or help you make those phone calls and help you push through something that's really difficult, and rallying that support is, whether you have insurance or not, I think is the first step if it's available to you.
Yeah, it's something that that can be so overwhelming, or that can have these systemic barriers, that just insulating yourself with that social network and recruiting any sort of thing that makes it less pressured, I think would be really useful. I've certainly sat with friends while they search through those lists and try and tease apart what's going to work for them. And there, Brandon brought up a good point that I also don't think about all the time. It's just sort of, in general, I'll join Noelle in the soapbox. Our preventative healthcare in the US is not fantastic, and our preventative healthcare and mental health is basically non-existent. We're not doing routine mental wellness checks. There are tools for that. There's screening tools online. You can pursue it if you really wanted to. But we're not looking for providers when we're feeling great. Partly probably because of stigma, right? We assume we're going to be psychologically okay most of the time, and we want to let that be and just kind of enjoy our lives. But also I think because they're outside of private pay, right? Like insurance reimburses when you have a problem. If there's a billable, like if I can put a code on your note that says you have this disorder, that's when the insurance is going to reimburse a lot of practitioners. So going because like you feel mostly okay, but want to have a relationship with a provider if you need them, that is often you're paying out of pocket for that, and that can be a little daunting. And it's just not as common a practice. So yeah, certainly recruiting folks that either have been in therapy and maybe have a relationship with someone, or who can just be with you as you're sort of going through this process, can be really useful. I think additionally, thinking about like paratherapies and things that can be supportive in the interim, whether that be chat or text hotlines, or things like, and I think we'll all have feelings back and forth about how this works, but like live journals and BetterHelp, things that might provide you a little support, or something that makes the interim time easier, can also be really beneficial.
The only thing I would add is and I think folks are really mentioning this quite beautifully, is that mental wellness and mental health is a continuum, right? We have something from like very mild distress to acute stress. And I think what we're talking about is we don't have a culture that gives us a lot of language to talk about that. And so like that's a whole like learning piece that I think we as a world need to kind of create. But accessing mental health at any point of that continuum is critical. One thing that I would recommend to folks is really know what your resources are. A lot of people, the first stop is their primary care provider, which is a good place to start with first line of defense psychotropic medications. They also provide referrals. Some providers, which they all should be, primary care providers should all be trained to do screenings like the PHQ-9 and the G87 that gets baseline scores around depression and anxiety. But then also, what are your other resources? Your insurance carrier, if you have health insurance, what does that look like in terms of I'm going to just say these very important things like your deductible, or does your mental health care cover, does your physical health care cover mental health care? Is it subcontracted to a third party payer? Are you able, or does your insurance also have out-of-network provider care? So there's a lot of providers, and I think Brendan made this point. There's a lot of us who don't take insurance because, you're still waiting for claims from August of 2022. I'm not going to say the name of the place, but you know who you are. So like that becomes a whole delay in payment, but I'm willing to swallow it because a lot of our patients use their insurance. But if you find a clinician that you click with, can you do out-of-network provider coverage and get a super bill so that you can get reimbursed? Or if you're going to do out-of-pocket, can you use your HSA money? Look at me, I'm just giving you all the ways to pay for therapy. Yeah, like what are your resources? Psychology Today, like better, know what your resources are and lean into them. And that's just some conversations. And I think the most important step of all of this is to know when you're ready for change, because it's a personal choice. But that's what I wanted to say.
No, I'm going to echo some of the things you just said, because there's some gold nuggets there that a lot of people don't know about. And it's really like an algorithm. Yeah. So if the first question is, do you have medical insurance or not? And if you have medical insurance, then the next step is to figure out is my medical insurance the same for mental health and for everything else? Because it's often not. So as a lot of people know, there are mental health parity laws, but they were never really completely put into action. And because of that, including myself, like my own healthcare insurance carves out what they say. So I have California Blue Shield covers my medical insurance, but if I want to do anything in the mental health section, it's this other company called Magellan. And it's not always obvious to figure that out. And the reason that's really important is because if it's all the same umbrella, it's really a really great place to start, like Noelle said, is going to your primary care doctor and saying, hey, who do you refer to? Because they're going to have the same insurance. They may work in the same healthcare system and refer you. If you're like a lot of Americans, including myself, I couldn't do that because even though I can see any doctor at my healthcare system, the exception to that is I can't see a psychiatrist there because I have a different insurance for psychiatry. So once you figure that out, then it's a process of contacting that carve out insurance and saying, you know, in my area, who are the lists of therapists and psychiatrists that you will cover? They'll give you typically a pretty big list, which is really intimidating. And the vast majority of people there, or it's either inactive contacts, they won't get back to you because they're full, or they will get back to you and tell you that they're full. But there often is one or two that may be able to work with you. Often there's not. And in that case, if there's not, which is a situation that's, I don't know how common it is, but it seems extremely common. The next step, like Noelle said, is actually trying to find an out-of-network provider. And there's a secret that most insurance companies will never tell you, but a lot of them do what's called gap exceptions. And a gap exception, you actually have to file with a potential provider. But so, for example, if somebody came to me and they said, you know, Brandon, I really want to work with you, I'd say, first, I'm flattered. But second, yeah, I'd love to work with you too, but, you know, I'm not in network with your insurance. And they're like, well, I called everyone on the list already. I'd say, okay, well, let's sit down together and file gap exception. So you have to find a mental health provider that's willing to do that. But if they are, I've seen this work numerous times. Well, then the insurance company that they have will temporarily pay me as an in-network provider just for that one person. They call that gap exception. They don't advertise it and they don't make it easy to figure out, but it does exist, especially once you call through all these lists. If that doesn't work, then it becomes a more challenging process, but it's still possible. Like a lot of things Noelle said already. There are a lot of insurance companies will still give some reimbursement for out of network, but you got to file it yourself. So you got to figure out with your health insurance company, how do I pay this up front, which honestly, a lot of us can't do. But say you can do that, then you can then file to your insurance company to get some level of reimbursement for that. And finally, so if that doesn't work, the next stage is actually a lot of providers or practices for different levels of financial need will do what they call sliding scale payments, where they heavily reduce or even completely eliminate any payments for certain situations. And a lot of times they don't advertise that. So it's not something you can see on their website. And it's kind of this very kind of grueling, persistent process of continuing to contact people. I know I mentioned Psychology Today, which is a great resource for finding providers in the area. But through searches and through like kind of systematic contacting folks and seeing who will work with you given your situation. I think I already mentioned it too, but teaching organizations often have programs like this, for example, that are kind of specifically for these situations. And then I think that were the big pieces that I want to make sure I kind of just said again. I know Noelle said most of that stuff already. It's just because they're recording this, if people ever want to look back and kind of have a more comprehensive view of at least what I think is an approach to that I've seen work.
Yeah, I think that's extraordinarily helpful. Thank you for kind of deep diving into that. I'm taking notes myself here to hopefully be able to send this out to the registrants of the webinar. So we'll do a kind of a follow-up one-sheeter. And as Brandon said, this is recorded, of course, but there was something else that you had mentioned, Brandon, I think it was NAMI, which is another resource. Did you want to mention that one as well?
Yeah, sure. So NAMI, National Alliance on Mental Illnesses, is a national organization. They are the largest of these grassroots organizations, which means that the organization itself is built and maintained by people that are on the receiving end of mental health care. They could be family members, they could be people who are in the patient role themselves. But this organization has been around for a while, and I love it. It's got chapters all throughout most of the country, a lot of times on the county level, so they're usually pretty available. They have a website, which is nami.org, that anybody can go to. But one of my favorite things about them, besides all the advocacy work that they do, is that they have hotlines, which are not just like phone hotlines, but they're chat rooms. There's ways you can email them, and they'll get back to you, and you can text them, I think, even. And they call these warm lines, which means that the people on the other end aren't hired to be there. They're people that have either been through the mental health care system and feel really passionate about helping other folks with it, or their family members that have been through it. And they're actual people who understand the system a lot, and they're someone to, really cares if you're able to get connected in the right way. So they're not a sort of referral service or anything like that, but they are a bunch of real people that have actually been through the system and can be a great support for people that are struggling with it. Because I can say everyone struggles with trying to get mental health care. It's universal.
So a thing that I would add is sort of a either first or fifth line option, depending, in terms of knowing your resources, and this can be very specific, and so sort of the search terms that you might enter to find it, is that there are some, and I'm not going to say that it's great, community mental health resources based on certain issues or need areas that sometimes come with funding. So in my area of work, I work with survivors of interpersonal violence primarily. Every county in New Jersey and Pennsylvania, and probably in several states, have domestic violence and sexual assault service agencies, many of which provide limited free counseling to victims and survivors of those forms of violence. And so if what you are struggling with has something similar, and we've certainly seen things for like Veterans Affairs, and we can talk about the VA, this is a separate issue, but around, combat trauma, around sometimes in certain areas that are well established, you can find things around suicidality and depression, where you may be able to find some degree of treatment, at least in the short term, through a community service agency that is doing it for very low cost or nothing. And sometimes those are good access points as well. Those are folks that are actively working to refer the people that they're working with to longer term care, to get them connected. They may know some providers in the area that are open or that are particularly good for the thing that you're looking for, or they have a relationship and they can kind of give them a call and see what's available. So you can sometimes leverage those resources to get to your next step.
So let's say we get to that next step and we locate a provider, and we jump through some of the hoops. What's some advice you could offer to folks that are maybe just meeting for their provider for the first time, and kind of just getting started in the process? Zach, I think you had some thoughts on that. If you want to take this one.
Yeah. I was gonna volley it to Noelle first, because I was like, you have this great phrase of sort of like know when you're ready for help, and I think that is true, right? It's but assuming you've jumped through the hoops, you have some commitment to this, but it can be really assistive in the process if coming into a mental health care setting, you've got some idea of what's going on or what you may want out of that relationship. Often folks don't. There's just sort of, they know something is up and they sort of want to feel better. But having sort of like this is what I would like to see different in my life, or this is what could be better, can be useful. That gives the clinician, that gives the person in front of you a place to start. It gives them things to try that may or may not be beneficial for you. And then the other thing is openness, right? Mental health care is different for a lot of us. It's not something we're trained to think about or that we necessarily know what to expect. And so lots of it in the initial stages is sort of an experiment of what's going to work for you, what's going to be comfortable. What can you engage in ways that feel useful. So an openness to, this person in front of me probably knows a little bit. Let's see what those ideas are, and attempting to engage in the things that you can. And knowing that some of it may feel strange, right? I've certainly chatted with folks who will have, first couple of sessions with someone, or they're engaged in the process. They're sort of like, oh, they asked me to do this worksheet, or they asked me to read this book or join this group. Is that something you would recommend? Does that make sense? And they're like, I thought I was going to talk to them and they were going to tell me what was wrong. And I was like, well, sometimes, yeah, there's some advice giving, or there's some like, this is what the research is telling us about the thing you're telling me. But often it is sort of adjunctive things, or it is personal exploration. And so, yeah, like that worksheet probably makes sense. It means that there's something underlying what the clinician is hearing that they want to explore more. They want you to try to get some insight on, and hopefully provide direction for what interventions are going to be the most effective. So it's a readiness, it's an openness. And then I think it is also a degree of self-empowerment and information. If the relationship is not working, if you think you can tell the provider that. You can be like, hey, you know what? I don't know if this setting or the way we're doing this is right for me. Can we try something a little bit different? And if that person is not open to feedback, leave. That is not what this profession is about. But it's being able to advocate for yourself a little, and being able to be like, I'm not sure this is right. And see, right? Just because, we've all had friendships or romantic relationships, right? That maybe started off a little odd, or you're like, this is a weird connection, but then it worked out. The same can be true with your providers. Let them know that maybe they're not meeting your needs in the best way, or like, I feel a little weird here. Can we talk about this? Most of us are open to that, or most good providers are open to that. I'm just going to keep referencing my experience, I guess. I work with a lot of female identifying women survivors, and superficially, just via gender, I sometimes represent or look like the person who hurt them. And that is sometimes a part of our treatment, right? We're working through being able to trust a person that kind of looks like me or resembles me in some way again. And so sometimes they bring that up. They're like, you seem great. I want to talk to you, but like, you're a man and that's weird right now. And I was like, yeah, it is. Let's talk about that. Are there ways we can get you to feel more comfortable? What do you need from me for assurances of safety? And if not, okay. And I'm lucky. I work in a university setting. I can turn that person over to another clinician relatively easily. And not everyone can, but let people know what you need and see what they can do for you. Because often once you're in, there's a little more flexibility than when you're not.
I would sort of echo everything Zach just said. And one of the things that I kind of want to outline too is just because for a lot of folks, and to be honest, when I say folks, I don't mean like general population or people who aren't familiar with healthcare. Like, I mean like my people with like 30+ year physician careers will contact me the first time one of their family members is like interacting with the mental health care system. And they're like, Brandon, walk me through it. I have no idea what's going on. And this is someone who's been working in hospitals their entire life. For most people, unless you're like an insider, it's very opaque. And there's a lot of, whenever something's opaque, we have even more kind of anxiety around it because we don't know what's going to happen. It's to be unknown. So mental health treatment itself has a lot of different aspects to it, which are not mutually exclusive. And some of these things I'm going to get wrong because I have like the neurobiology perspective. So you'll get like my way oversimplified like explanation of some things. And then, Zach and Noel can fix it. So in the big picture, there are what I consider like interventions that a medical doctor might do, which are going to be things like psychotropic medications. So these are common things like brand names like Prozac, which is fluoxetine, Wellbutrin, different antidepressants, anti-anxiety medications. There's dozens of them. This could be prescribed by a primary care doctor. They're often prescribed by psychiatrists as well. So that's like sort of the medication aspect. There is what we call the brain stimulation aspect, where there's different types of methods that are actually used to electrically stimulate the brain. And by doing that, we can treat that. So transcranial magnetic stimulation, transcranial direct current stimulations, or some FDA cleared types ways of treating, and that may be something that a physician recommends. There are numerous different types, I call them flavors of different, what I call talk therapies, which is like my way over simplistic kind of big picture aspect of it, but they're really different. And they work really, really well for some people for certain disorders. But just because sort of one maybe doesn't work for somebody, it doesn't mean that that particular one with either a different provider or a different person or a different illness wouldn't work really well. And that can be absolutely bewildering if you're in the chair, so to speak, and the person receiving that. Because even as someone who's worked in mental health for years, it's even difficult for myself who doesn't do these talk therapies every day. To really understand exactly when to use each one or how to use each one. And some of them, I think as Zach mentioned, some aspects of it are sort of very formulaic, which can be really great for certain things. They include things like you're going to be doing certain homework, you're going to be talking about highly specific things, you're going to be putting numbers to symptoms, you're going to be meeting on a very regimented basis. And those things can be used to treat things like depression, anxiety. There's very specific versions for treating trauma that Zach I'm not even going to try to talk about because Zach's the expert. But then there's also things that are much more kind of, I consider them sort of more free flow. So one of the older types, people always say, oh, this person Freud, what was he doing? So he was, the founder of psychodynamic psychotherapy, which is still very, very prevalent. It's used very often, but it's very different from these more formulaic, more sort of very specific type things. Like I have folks that I treat on the medical side who are engaged in psychodynamic psychotherapy, and they may see a provider multiple times a week, even in the more extreme sense. Some of them are seeing their provider 5 days a week for years, on sort of the one end of the spectrum, but typically at least once a week. And really, they're the one the patient's doing most of the talking, the provider's listening, and every so often making reflections. There's really no exact course of it. It's very free flowing. There's folks that'll provide sort of more sort of classical, what they call supportive therapy, where they're there to make sure that you feel supported and like someone's there to provide empathy and listening. And then there's a whole lot of other ones that I haven't even mentioned. And the reason I really bring that up is because kind of a lot of folks like myself, before I learned about these things, I thought, oh, there's talk therapy and that's like a thing. But like anything else, there's actually a huge spectrum of it. So I'll let the experts take it from there.
I'll just jump in because I think it bears repeating. We're all talking about outpatient mental health services. And I really want to put this out there that like mental health, again, from acute to mild, if you're experiencing suicidality or homicidal ideation or psychosis, that's really debilitating. I mean, we have inpatient services, right? Like the most sort of secure and focuses on stabilization with violent withdrawal from benzodiazepines, alcohol, and barbiturates, detox, like rehab. And then we have sort of like outpatient once a week. And then there's programs in the middle that look at severity of symptomology. So I really want to put that out there in terms of what we are specifically talking about, like the outpatient treatment, but mental health from 0 to 100, there are different access points. And if you're feeling suicidal, you don't have to wait on a wait list. Go to the crisis response center locally, call the suicide hotline. I want to mention that. And also just one of the pieces, I think what folks are describing, relationships are vehicles for change. And so knowing what the relationship is with your treating clinician, whether it's a mental health provider, a primary care provider, these are, that's an important thing to turn towards. One question I got privately, and I just want to put that out there for folks who are undocumented or uninsured or don't have papers, people can access mental health through federally qualified health centers. There are often federally qualified health centers in all different parts of the country that provide integrated healthcare, which is a behavioral health person, and providers often sometimes will work in FQHCs to provide that type of psychiatric care for folks who are uninsured or again without papers. So I just wanted to put that out there.
And it's also state dependent aspect too, because in California they have, for example, county-based programs specifically. So I've had a number of folks who were not were undocumented, but actually had state-sponsored insurance support, which sounds counterintuitive, but in certain states it is possible.
Thank you both for touching on that. And thank you all for touching on all of that. I think there's some huge takeaways in everything that you just shared with us. So I'm sure it was very advantageous for our audience. But in the interest of time, I wanted to at least touch a little bit on the other, it was hard when we were planning this to how do you whittle down mental health into an hour. So we certainly just talked about the access points, and I think that's huge for people. And so I'm glad we did spend a lot of time on that. But the other general thought that we touched on was how does mental health, how is it impacted by culture? And again, that could be a whole nother 3-hour webinar just in and of itself, but I did want to touch on it a little bit because I think as of late, there is a lot of change in a good way, mostly, I hope, around that, but certainly still stigma. So does anyone kind of want to touch on that a little bit before we open it up?
Yeah.
Oh, go ahead, Zach.
No, please go for it.
Yeah, so I created Mango Tree Counseling and Consulting about 2 years ago with the rise of anti-Asian hate. And what I found really interesting, again, this is something that me and my practice has really focused on, is like the mental health framework that I was trained in here in the US is a particular type of framework. It's a Eurocentric, white, Western kind of framework. And we don't all live in a world like that, right? Like we live in a world that's diverse and has equity. So there are different nuances in mental health and in the canon of mental health that haven't been introduced. So I work with a population that is Asian American. We have about 6 different languages on board, and big part of what the feedback that we often get is there are stressors and anxieties around my psychosocial identity that isn't accounted for in the traditional canon. Can we talk about that? And so BIPOC clinicians account for 4% of psychological workforce staff. So that's not a lot. And sometimes in mental health treatment, people want to feel like they're seen. They want to see themselves in those provider care. So I do want to say, like, culture and identity does matter. The epistemology of how we learn things are framed after a particular experience. And I think more folks that are out there doing this work, changing the culture, we can have more of an equitable program. But yeah, I just want to put that out there.
Yeah, and I think, and this goes for all sorts of identity, right? So like I work with a number of queer or LGBT identifying clients, and they're often looking for sort of the same thing: someone who understands parts of that experience, has a comfortable with sexuality, has a comfort, there we go, can talk about topics that might not be able to be discussed in the family of origin or at home. And my thing, again, on the self-empowerment piece, is in your search or in your initial work with a provider, it is okay to go in with questions. Like, yes, you're seeking this person as an expert or as sort of a helper, but they are there to meet your need to a degree. And so if I'm working with someone on referrals or finding an outside of the university provider, I'm like, it's okay if you ask them questions. What's your experience working with trans clients? Have you had many clients that are Latinx identifying? That can help generate comfort and can help give you some information about the framework that person is coming from and whether they can connect with you. And if you are, and it can be hard, right? Many of us are trained not to do this. If you are feeling that there is a disconnect because of a cultural or identity factor, it is okay to make that apparent. And how the person responds gives you information and can help you with that connection. I've had some wonderful connections or experiences with clients when, I'll be 5 sessions in and they're like, I haven't talked about this, but this is where my family comes from. And this is everything that encompasses our traditions. And this is my spirituality. And I was like, oh, here's 6 new things I can use that are helpful in your healing and treatment. Generally, I ask and try and elicit that stuff sooner, but sometimes, folks come in with lots of stuff they want to say, and you don't always know right away. And so all of that stuff can be strengths in addition to equity issues and things that we need to address on the provider side.
Thank you, guys. One thing under this umbrella that Noelle, you kind of touched on in our previous conversation was communication and miscommunication and misinformation. Did you want to touch on that a little bit? I mean, I know, you know, your sources are your sources. Some people may seek information in certain places, but you did touch on that a little bit in our previous conversation. If you just wanted to mention it here.
Oh yeah, man. Yeah, so you know, again, we are at the age of information, which is wonderful. When I was at TCNJ, we had a computer lab. Now people have computers on their phones. So we are in a different age of information, and people are accessing a lot of information on things like TikTok and Instagram. And you know, what I have found, and this is just anecdotally, and this is something in our group practice that we talk about, you know, there's a lot of kind of like misinformation that's out there around mental health. Like everything is toxic, and you know, like I'm triggered, so it's over, you know, and I'm being gaslit because I'm hearing something that I don't like. So you know, one thing I love that, but you know, on the other hand of it, you know, I don't want to be rigid. On the other hand of it, I think it's so important that we're having more language. So you know, one thing I would encourage folks, especially because finally in 2022 people are interested in talking about mental health, right? And people have more language around sensitivity, around severity of symptomology. But I think what we obtain in the internet and particularly social media, do yourself a favor, talk to a provider, note it down, write it down. Wait, we don't even write things anymore. Text yourself or whatever. And you know, like really be curious and talk to do the research and talk to trusted providers around these things. There's a, you know, and it's also developmental. I don't want to even go there, but like there's some developmental stuff that goes on. But yeah, I think providers exist not only as treating professionals, but as folks that can provide perspective and education around particular forms of suffering. You know, just because it's real doesn't make it always true. So like, again, this idea of really becoming a good consumer researcher on your flavor of suffering. Please be sure to do the research on that. Yeah.
And it's such a struggle because there's some great information and it provides access to people that may not have it, and it normalizes experiences. And like I even see great mental health TikTok about this is how depression looks different in men. This is how people misdiagnose Black people because our cultural expression is different. And that's all so great. But then you are filtering through like, if you don't know, how do you know what's the good stuff? And I do spend a lot of time helping people attach language to their flavors, and you know, walking down like, okay, well, this is what a trigger experience feels like. This is how we use it in the psychological world. Could you actually be experiencing this thing? Oh, it is that thing. Okay, now I know what to do, and this is how we can help you with that. So it's, I don't know. It's an interesting time in our access to information. What I do like is what I find with a lot of the good mental health pop culture information, there's citations. Like even on Instagram, even on TikTok, people will link where they found stuff, or they'll link their credentials. There's a lot of good providers who have Instagrams and TikToks where they're sharing information that can help filter a little bit.
Yeah, I think the important takeaway there is do your own research and don't just take it for face value necessarily. So thank you for just kind of reiterating that, and kind of a general reminder for a lot of things in life, right? Not just mental health. Social media is so prevalent. So before we open it up to the audience, are there any you know, last takeaways that any of the three of you would like to add. I know we touched a little bit about, so what's the future look like? And we already kind of covered a little bit of that throughout this conversation. But Zach, I know you at the top of this discussion said, it was a little bleak, but we're going to get to all the good stuff. And we have, we've offered some good stuff. But are there some optimistic things to look forward to in the future of mental health?
Brandon, that's you.
Well, I mean, there's many ways of looking at it, right? So obviously one of my focuses is more on the technological side, but and instead of boring people with that part, I think that one of the things that I have seen a lot of, and the part that I like to encourage people to become a part of, is really the advocacy part, because we see that we're on a change here, and as we see more people talking about mental health on social media, as we see more people reaching out for care, we see more people utilizing the mental health care system. There are ample opportunities for advocacy, and it's one of the few things, we said the midterm elections, but mental health is one of the few things that's really largely bipartisan. I often go to events for mental health advocacy and speak with politicians from all sides of the aisle, and a lot of them come with really equal fervor. And I've been seeing more and more events where folks are really pushing donors to help. And it really requires a full kind of population effort to make those changes. Most things in healthcare didn't start out easy to access. And typically when a new treatment comes along, whether it's in mental health, whether it's a talk therapy, whether it's a medication, whether it's a procedure, whether it's for any type of medical illness, it's typically not something that's widely available or covered. It's only after the population really speaks up and continues to speak up and really push for that and advocates that do things change. Mental wellness is really on the tail end of that for a couple of reasons. And one of the bigger reasons is stigma. It's been so hard to speak up before because there's really a lot of difficulty and risk in doing that, and there still is. But as that changes, I think one great way, if you are interested in getting involved more on the support or advocacy side, is I'll sort of point people back to the NAMI folks, because I think they're really amazing, and they're really helpful for getting engaged at a very small level or a larger level to help push the system forward so it becomes better.
I'll jump in quickly just about like the treatment modalities that are out there. When I was getting my training in 2007, it was all about CBT and symptom suppression and distorted thinking. And there was like a lot of rigidity and it was all about symptom suppression. And more recently, even though there have been therapies in the 80s, there's a rise in what we call third wave behavioral interventions, which really incorporate things like, what a novel concept, acceptance, compassion, mindfulness, multiple truths, right? Like it's not just one or the other. I feel like this is kind of consistent with what's going on culturally, but this idea of how do we create alignment versus right or wrong. So I could at least say in my training and as an instructor in different graduate programs, I'm starting to see a much softer, a much more compassionate, a much more integrated approach towards mental health healing. And so I think we're hopefully as clinicians going to change our language around how we approach suffering and healing differently than maybe we have in the past. And I think things like the opioid crisis and looking at other sort of larger scale things turns towards accountability in our systems and the harms that we have done. So I think that there's more turning towards that I think I'm seeing, not as a whole system, but certainly the attitudes I'm starting to see are more turning towards.
All right, guys, thank you so much. We are already almost at 1 o'clock. I can't believe it, but I do want to take the last few minutes to open up to the audience. If there's any questions, please. I know our three panelists had said to me, take advantage of this time. There are three professionals on this call, and so if you have some questions that can somewhat easily be answered, please, take advantage of it and ask them. Like I said, I will also share a one-sheeter and some ways to contact the the 3 alum here after the call and follow up. But while we're still live, please ask some questions. Feel free to do so. But in that time, I just want to personally thank you guys again for taking the time in planning this, in being on this call, our planning call. Like I said, I know it's time out of your lives and out of your busy schedule. So thank you for taking some time and energy to share this with me, with all of us. Really appreciate it. And I'm also sorry for the leaf blower outside here. So, okay, we had a question come in. What is the difference between group and individual therapies? Which one would be recommended as a first step? Does this speak to anyone more so than another?
I used to do IOP, but so I guess that might count. So first,
Noel, what is IOP?
Oh, I'm sorry, intensive outpatient program.
Okay,
this is a tricky question here because I don't have a case conceptualization of the client, but I would say both are helpful. Group therapy is particularly helpful when there's a want for interpersonal learning, peer-to-peer support, universality, and a craving for cohesion with others who might have experience. I used to do IOP work with folks on methadone maintenance and substance abuse where there was high levels of shame around particular behaviors. And there's a kind of ego strength building when you have a sense of universality when you're with people that are going through the same thing. Individual therapy is also helpful. I guess it depends on what the presenting issue is and the sort of socio-cultural energies around the suffering. I hope that was succinct.
And they're not mutually exclusive. I know I have a lot of clients who are engaged in both, but both for different reasons. Would be great answer Noel gave.
And in terms of order, I've seen folks start in a group because they weren't ready to have this intense sole focus on themselves, and the group helped them get to that. And then I've had people that really need to do their own work first, and then the group is sort of a next step. So it can really go either way, depending on need, comfort, and sort of the overall context of the person involved.
Awesome, thank you guys. All right, well, I haven't seen any other questions filter in, but certainly feel free to reach out post webinar and we'll do what we can. But again, thank you guys. Yep, and now all the thank yous will come in, I hope. I know this was extremely informative. Thank you for validating. Thank you for sharing. Thank you for informing the group. A lot of takeaways that I think people will carry with them. So for the audience, thank you for joining and enjoy the rest of this beautiful day, at least here in New Jersey.